Thank you very much for the invitation to talk. So what I'm talking about today is about building an evidence base for congenital cardiac surgery. First thing to say, if I can make the slide go, is that I don't have any disclosures related to this talk. And what I wanted to talk about today falls into two parts. So the first is about research in congenital cardiac surgery, or really the lack of it, and particularly the lack of randomized evidence to inform clinical practice. I'll then talk about the James Lind Alliance Priority Setting Partnership, which some of you may be familiar with, the national strategy that evolved from the PSP, and the primary component of that, which is the Congenital Heart Research Network in the UK and Ireland. The second part of the talk, I thought it would be interesting for you to get an insight into how you move from an idea to a trial. So I've given a sort of pathway that I've used for doing that. And use a couple of worked examples, particularly the Destiny trial of cardioplegia, and also some information on our proposed pulmonary valve replacement trial. So, research in congenital cardiac surgery. Well, as you know, congenital heart disease is common. About 12 children are born every day in the UK, and a good percentage of those undergo surgery, quite often in the first year of life. And over the last 30, 40 years, survival has continued to improve. Mortality is now probably around or less than 2% for children having cardiac surgery, but significant morbidities remain. The good news is that once you get past those hurdles, pretty much everyone is expected to survive through childhood into adulthood. And it's very old figures because there's no recent data, but it's estimated that there are 250,000, but I'd probably say that's probably more like 350,000 now, adults living in the UK. However, pretty much across the board, they face reduced long-term survival, increased burden of re-interventions, and numerous types of late complications. And the problem is, particularly with the emerging population of adults, but even throughout childhood, we don't really have the evidence to inform our decision-making on how to manage these patients. Looking on the Cochrane Library, there are fewer than 20 reviews, and several of those are repeats. So it's less than 0.2% of all reviews in the Cochrane Library, compared with the incidence of congenital heart disease, which is 1%. So really, we need high-quality clinical trials to improve outcomes for our patients. This is a drum I've been banging for a long time, going back to when we did this study, which was published in 2018, and looked at all cardiac surgical trials from January 2000 up until 2017. And really, we wanted to understand the landscape, particularly in children's heart surgery, as to what trials have been done. The good news is there were a lot of trials. The bad news is they were nearly all poor. Single center studies, few participants, poor quality research, and therefore having no impact on patient care. And as you can imagine, there's been a lot of time, money, consent, and effort put into these studies, and they've achieved nothing. Apart from a handful, probably about 15 that have actually done anything at all. But that's in getting on for 20 years worldwide, which is poor. So you may say the UK would be better, but alas not. Up until the point that we did this systematic review, there'd only been 10 trials published in those preceding 18 years, all single centre phase 2 trials, total of 430 participants. And that was less than 1% of the 65,000 children who'd had surgery during that time. And if you compare that with paediatric oncology, where around 70% of patients are enrolled into phase 3, later phase trials, we are nowhere near integrating clinical research into clinical practice. And this figure of less than 1% really caught on, and it was picked up by the press. It was featured on Sky News, and really the headline was that British children are being let down by the lack of cutting-edge trials. It also then formed part of the British Heart Foundation's Christmas sort of fundraising campaign to particularly focus on congenital research. So we wanted to think about how do we start to address this? It's a big problem. There's so little out there. Where do we go? And we followed in the footsteps of the adult acquired disease surgeons in the UK, in that we undertook a James Lind Alliance Priority Setting Partnership. So the JLA is a national non-profit organisation. It's now part of the NIHR, It's been around for more than 20 years, and it's named after the guy in the picture, who was a Scottish naval sailor. And he conducted the first clinical trial, which was giving people different types of food to see if it prevented scurvy. And he found that oranges were highly effective. I mean, the orange group only had 2 people in it, but neither of them got scurvy. So the James Lind Alliance have these things called priority setting partnerships, and essentially it's where they bring together patients, carers, and clinicians using a well-established framework with the aim of prioritizing medical research. There's more than 200 have been completed worldwide by now, mostly in the UK. And the aim is to identify and prioritize evidence uncertainties. We want to find questions that can then be answered by research. So I led the Congenital Heart Disease PSP, not just focused on surgery, but importantly focused on all of congenital heart disease, and particularly the diagnosis, treatment, and outcomes. We were fortunate that it was funded by George Davis, who's some of you may have heard of as a fashion designer. He founded Next, and he's the George in Georgia Asda, the UK's biggest clothing brand. But he's also a philanthropist and grandfather of someone with congenital heart disease that we've looked after. So we reached out to partners across the UK, charities and professional bodies, and then we were grateful for the help of other partners to help us get the message out there about the study that we were doing. So we focused on the management of congenital heart disease, including prior to birth, particularly diagnosis, treatment, and outcomes. We set this up during COVID, so a lot of most of the meetings we had were via Zoom. And we specifically excluded things like the causes of congenital heart disease, because that's something that, whilst in the medium to long term, might have a huge impact on patients being born with congenital heart disease or being born without congenital heart disease. We felt that would detract from our aim, which was to generate research questions that could be answered for relatively quick clinical benefit. We also excluded acquired heart disease and any of the comorbidities that might go along with congenital heart disease. And so we asked in our survey, what questions would you like to see answered by research relating to the diagnosis, treatment, or outcomes? Just to run you through the process, and so you've got an idea of how long it takes to do things like this. So it was originally raised in June 2020 at the SCTS Research Committee, and at that time I was the congenital lead. We secured funding in January, which was really a key step to get the process going. Held our initial committee meeting in March, and then by the time June came round, we'd put together and started an initial public survey. So it was promoted, and the aim of this was to generate questions. We had more than 500 responses and over 1,300 questions, which was a lot for us to go through. So it took quite a lot of time to filter those questions, to put them together and merge them into summary questions, to check against the evidence to make sure that they weren't already answered. And then we ended up with 56 child antenatal and 47 adult uncertainties. Now, we decided that we would split the child antenatal from the adult because of 2 reasons. First of all, adult is a growing population of patients that are underserved by research. And secondly, we imagined, and it came to be the case, that in the initial survey, by far the biggest group was parents. And we didn't want the adult uncertainties to be swamped by the parents. We then progressed that to a second survey, which was aiming to prioritize the topics, and we had over 250 responses to each of the surveys. From that, we refined and came up with 26 questions from each of the surveys that we then took forward to workshops, and those were held 5 years ago, around about this week actually, involving patients, parents, charities, and healthcare professionals. And the aim of those workshops for both the paediatric and the adult was to agree a top 10 list of priorities. And really the structure that we followed is the standard James Lind Alliance approach for addressing this. As I'll discuss in a bit more detail, we then took that forward to develop a national plan for how to address the priorities. And we launched the PSP at the BCCA national meeting. So this was the child workshop. The JLA have a standard approach for how they do these in-person events, and we were fortunate that by the time we got there in the summer of 2022, restrictions were lifted and we could hold it in person because it was a really fulfilling day, both days. of the workshops. And you can see from the tables, the sort of red, yellow, and green, that the priorities in small groups are ranked, and then you go through a multiple stage process of putting them into an order of priority. And it was a really fascinating event. I was there as an observer, and it was quite rapidly emerged what were going to be the priorities. So these are the top 10 child antenatal priorities. The number one was about reducing damage to organ during surgery in children to reduce complications. And then the others were around pre and postnatal screening strategies, interventions for brain development, reducing the frequency of need for re-operations, using technology to deliver personalized care, mental health, quality of life, making interventions less invasive, a specific one on the Fontan circulation, and then more broadly on long-term outcomes. The next day we held the adult workshop, and it was the same process going through with the questions. We had an entirely different group of individuals, so none of the patients or parents was crossed over, and neither the clinicians, but just the same facilitators. And we came up with the top 10 adult priorities. And you'll notice that with the ones that are asterisked, those are actually the same questions that made it into the top 10 the day before. We specifically didn't share what had been prioritized for the children, but as you'll see, 6 of the adult priorities are the same as the pediatric priorities. So they were less invasive interventions, Fontan circulation, mental health, technology, an adult-specific one related to pregnancy, another on heart failure, another on arrhythmias, and another on transplantation, and then 2 more crossovers on quality of life and reducing the needle frequency of reoperations. So we published this in late 2022, and Open Heart changed the way that you can access the metrics on it. So I don't know how many times it's been downloaded, but it's been cited 32 times to date. So we're having an impact on the literature. But from the very start, we wanted to move beyond the PSP. So as mentioned in the top 10s, 6 were on both lists. So there were 4 child antenatal, 4 adult, and 6 that were effectively throughout life. And whilst the questions were quite different, many of them are amenable for clinical trials. And whilst many PSPs leave it there and allow others to sort of pick up the gauntlet and run with it, we were very sure and keen from the start that we wanted to use this as a catalyst, really to change the way that we do research in congenital heart disease in the UK. Prior to this, there had been the odd study that was collaborative, but very few, and no multi-centre clinical trials in paediatric cardiac surgery. So we took it forward to develop a national strategy to address the priorities, endorsed by national bodies and also supported by NHS England. And that was this document called Transforming Collaborative Research. And this has really been almost as important as the PSP itself in terms of giving a roadmap for how we take this forward, because it's all very well to do it, but if you just leave it there, it doesn't have an impact. And we wanted to put in place a process to have that impact. We were aware that we weren't the only people to do these kind of things, and so rather than reinventing the wheel, we got advice from others, particularly the Adult Cardiac Surgery PSP that became the National Cardiac Surgery Clinical Trials Initiative that you may well be familiar with, led by Professor Gavin Murphy in Leicester. And then in the United States and Canada, the NIH-funded Pediatric Heart Network, based in Bethesda near Washington. I visited them twice, and they were amazingly helpful and really open in sharing their experiences of doing multi-center trials, which was fascinating. And that led on to developing the Congenital Heart Research Network. So this is a collaborative network for multi-center studies across the UK and Ireland. And the aim of it, as mentioned from the outset, is to do impactful studies. We don't want to waste time, money, effort, and consent in studies that go nowhere. We want impactful studies that make a difference, change practice, and improve outcomes. But we didn't want to limit it to congenital heart disease. That was the nature of the PSP as a sort of defined patient population. But pediatric cardiologists deal with inherited and acquired diseases as well. So the network is broader than just the PSP. It's been adopted as a formal subgroup of the BCCA, which is the British Congenital Cardiac Association, the national body for really the management of congenital heart disease across pediatric cardiology, cardiac surgery, and adult congenital, and affiliated specialties. So we report to BCCA Council, and we get admin support from the BHF Clinical Research Collaborative, which is a body set up by the BHF to provide support for all sorts of different groups, but particularly for joining together to do research. It's overseen by an executive committee, which has got a network chair and myself as the director, and we link with other organisations, including patients and charities. So just a couple of slides on the network. Well, I can see there's a few questions in the chat, but I can't read them at the same time as doing the talk. So we'll either save them for the end, or if people want to shout while we go along.
I've had a
So,
look through them, and I think we can save these ones for the end.
Okay, that's fine. Unless anyone shouts, I'll just keep going. So the mission statement of the network is fourfold: to improve the health outcomes of those with congenital heart disease, pediatric inherited and acquired heart disease, to support the conduct of high quality research. I didn't go into the detail about the studies, but the studies were really poor that we found, the congenital heart disease trials internationally, really poor. I mean, we're talking like 7%, I think, of them that were drug trials had a data monitoring board. Now, I appreciate that some of those studies were done 15, 20 years ago, but that's inconceivable now in the UK that you would do that. We wanted to involve patients, families, and charities throughout the process. They'd been heavily involved in the priority setting, and we wanted that to continue. But we're also aware that the lack of clinical trials meant that the workforce is actually never been skilled up in conducting trials, whether as the chief investigator, a local principal investigator, or really just helping in the conduct of the studies. Whereas in oncology trainees get funded to do an MSc as part of their training, specifically so that they can be clued in, because most of the patients they see are going to be in a trial of some form. That's not the case across congenital heart disease in the UK. So our objectives were broadly to bring together the centres in collaboration, to provide a framework for investigators to develop and lead multi-centre studies, particularly clinical trials, to promote patient and public involvement and engagement in research, to use routinely collected data better. We have such a wealth of data, but NICOR is so difficult to access and get that data out. And to facilitate research training so that across the board, people are better informed about research, how to conduct research, and to help trainees become the next generation of research leaders. So just over a year ago, we held our first development workshop, which brought together people from across the UK and Ireland. Every centre was invited, and that's really helped to shape the development of the network. And it was generously funded by a family and also the BHF Clinical Research Collaborative. And then alongside the network, we're also in the process of setting up a national patient and public involvement group specifically for congenital heart disease, to include patients, parents, and charity members with lived experience, whatever that may be, and to continue providing that voice for those people to continue to shape the research agenda following the PSP. They'll provide strategic input to the network, actively contribute through all stages of the research, help with those tricky things like lay summaries that are always sort of overwritten by clinicians, to help us communicate the research better. And in return for that, all of the studies that are recognised and sponsored by the network will acknowledge patient involvement through co-authorship and outputs. So at the moment, we're in the process of setting up a core group. We've got half of them, and these will provide a focal point for national PPI input. So if people are doing a study and they want to get specific input on a particular area on a national basis, then they can approach this group once it's established. And then secondary to that, we'll have a pool of patients, parents, and carers with specific interests. So we're currently in the process of adapting the BHF CRC's National Research Database. This is a platform across all of cardiovascular medicine where people, whether clinicians or patients or parents or whoever, can sign up and express an interest in a particular area. At the moment, we've just got congenital heart disease as a blanket box, but we're working with the BHF CRC to modify the database so that if you, as a patient or parent, sign up and you click congenital heart disease, it gives you a list of the priorities and you can indicate to us which priorities you're interested in, and we'll then have access to that group to help frame specific studies. So moving on to the second part, which is about what happens if you have a good idea. How do you operationalize this? How do you go from an idea to a trial? So these are my thoughts and experiences. But what I would do is to do an initial literature search, because there may be evidence in that area. It might be hidden away, or it might not exist, or it might be hard to find. If someone answered the question already, if they have, then great, you can find the answer. If not, then where are the gaps in knowledge, and how can you take that forward to try and answer them? That then leads on to developing a research question and eventually a trial proposal. But of the things I'm about to list, and as I'll show on subsequent slides, some of these can be quite a lot of work, so may need external funding and a fair amount of time to complete. So my approach to this is, first of all, after you've done the initial literature search and haven't found an answer, to do a more formal approach, so a systematic review and, if possible, meta-analysis. That allows you to confirm the current knowledge and any gaps in that knowledge, and also to identify other things that would be useful for trial, such as identifying what outcome measures people have used in similar types of studies. Next, if you're looking to recruit patients across different centres and you want to change practice in some way, doing a survey to understand current practice and people's willingness to change their practice within a trial, and particularly to randomise between two different options, is really helpful. And I'll come on to a couple of examples of that shortly. Involving patients is essential, and particularly if you're applying to the ACHSA, the British Heart Foundation, or really any of the other major funders for a trial, you'll need to demonstrate how patients have been involved throughout the journey of the trial, so start that early. Perhaps through a focus group or a targeted survey, so you can understand the patient's perspective, what's important to them, what aspects of the trial design may or may not put them off taking part, what are the different barriers and facilitators to recruitment, and they can be incredibly helpful. For a trial I'm coming on to talk about in a minute, we've done a number of focus groups, and we've got another one next Monday to help us shape the direction of the trial for an application that's going in the next 6 weeks. And then finally, think more broadly. What else would help you? What other information do you need to help develop your research question and shape the trial proposal, whether that could be a collaboration with industry or something else? So I thought it would be useful to give a couple of examples. So the first one is about cardioplegia. So as everyone on the call, I'm sure, is aware, cardioplegia is fundamental to doing anything inside the heart, so that you can stop the heart, protect it, and access without getting very wet. But the problem is that whatever you use, cardioplegia-wise or other, to protect the heart during that time of aortic cross-clamping, it always leads to myocardial injury, as indicated by troponin release. And this is, by definition, not a good thing for the heart. So there's room for improvement. And we saw from the priority setting partnership that in children, minimizing organ damage was the #1 national priority for research. So we got interested in del nido cardioplegia. It's widely used in the majority of centres in the US and Canada in paediatric cardiac surgery and a growing number of adult centres, but there really is limited evidence to support it. Its growth has mainly been through word of mouth, emanating from Pedro del Nido himself in Boston, of people liking what they saw and taking it back to their practice, but without that evidence to underpin it. It's a type of blood cardioplegia. It was originally designed in the sort of mid-90s for the immature myocardium, and I could probably do a whole talk on what that means because it's not entirely clear. The main difference from other types of cardioplegia is that it's got a higher lidocaine component, and therefore it leads to a prolonged period of diastolic arrest through sodium channel blocking, and therefore its dosing is much less frequent. Del Nido himself does most operations on a single dose. People who are slightly more paranoid might give another dose, but it might not be for 60 to 90 minutes, compared with St. Thomas's, where you'd be giving a dose every 20 to 25 minutes. So we would think it makes the operation more efficient. The other downside for the UK is that prior to what I'm coming to talk about, it had never been commercially available. So we thought, could we do a trial to compare del nido with St. Thomas's blood cardioplegia? So following through the steps, we started with a systematic review. So this built on a lot of the searches that we'd already done for the bigger trial systematic review, but we were looking for clinical trials comparing types of cardioplegia. We used a standardized approach for searching databases and independent screening of abstracts and papers, and we identified 26 trials of cardioplegia in children. But as you might imagine from the sort of more wide-ranging systematic review, these were all small single-center studies, few patients, low quality, and at high risk of systematic bias. So really not that useful. The most common endpoint was a troponin metric, most commonly area under the curve. But the problem of having a lack of standardization is that there was so much heterogeneity in the endpoints, whether that was the different troponin assays, the different timing of the measurements, the different ways of putting that data together, different metrics used, that really we weren't able to do a meta-analysis of the data because it was too disparate and they were comparing too many different solutions. Only 2 of the studies we identified at the time compared Dalnido versus St Thomas's. And an interesting point was that in all of the studies we identified, there were only, as best that we can work out, 21 neonates across all of those studies. But we know that neonates are a high-risk group, and the effects of cardioplegia related to the immature myocardium are less well understood. So we concluded that there were no late-phase trials in children, and therefore the best solution for myocardial protection in these patients of all different ages is unknown. That was published, and that helped to support our case. And then we also conducted a national survey. So surgeons and chief perfusionists across the UK and Ireland were contacted. We had a really good response rate, particularly from the perfusionists. I did call up the last one and say, you're the only one who hasn't filled it in, and so he did. And we found from that 81% of surgeons use St Thomas's blood cardioplegia or similar. So that really is, or was, the standard of care in the UK. Not surprisingly, no centres used Dalnido because it wasn't available. But reassuringly, the vast majority of surgeons would be willing to randomize patients. And of all the different options, Dalnido versus St Thomas's blood cardioplegia was the one that scored the highest. So 91% of surgeons were happy with that. So we concluded that really a trial comparing Dalnido and St Thomas's in the UK was feasible. And again, we published that paper to help support our trial application. And then we undertook pretty extensive public and patient involvement throughout the different stages of the development. So it was key to the setup of the trial, the conduct and the reporting of the trial. So initially we held a focus group. So we brought together the parents of children who had had cardiac surgery at several centres because we wanted to understand their perspectives on clinical trials, factors that might affect their willingness to take part that we might be able to modify, and also the concept of comparing the standard of care in the US and the standard of care in the UK. And that went down very well as a concept. One of the parents from that group went on to become a named PPI collaborator on the funding application and therefore contributed to developing the trial proposal and the plain English summary. When we got to the protocol stage, that was informed by some previous work that we'd done. So I haven't mentioned here, but we did a previous study which was looking at remote ischemic preconditioning in children at 2 centres, and that's it's called the BRIC trial. And on the back of that, we did a sub-study where we interviewed parents who had both accepted or declined to take part in the trial to better understand their decision making. And that informed some of the ways that we've taken forward into subsequent trials on how to approach parents, how to give them access to the information, and how to try and smooth the process to maximize uptake. We also had parents reviewing the draft patient information leaflet to improve clarity and readability. And eventually 2 parents participated in the trial steering committee, which is an independent committee overseeing the running of the trial. So you can see from this that patient and public involvement really runs throughout the whole trial, really from the concept through to the conduct and reporting. Next was collaboration with industry. So as mentioned, Dalnido hadn't been available in the UK. So we struck up a collaboration with Stockport Pharmaceuticals. They're based in the Northwest and they're an NHS manufacturing pharmacy that makes sterile products and particularly specialised in clinical trials. So in the US and elsewhere, Dalnido has only been available as a compounded solution. So what that means is that They essentially get a bag of the base solution, which is plasmolite, and then inject into it the different components to make it up to the right concentration. But the problem with that approach, even in a sterile environment, is that it's got a limited shelf life. And the commercial products available have got a 45-day shelf life. And that's mandated by the FDA based upon the way that the solution's made. So, funded by the BHF, we undertook some preliminary work to develop Dalnido as a terminally sterilized product. And we wanted to do this because we wanted to try and extend that shelf life. We then undertook a sort of rolling program of stability testing at different temperatures so that we could better understand how to maximize the durability of the solution. And we found that refrigerated, the product could have a 12-month shelf life. And we submitted that data to the MHRA and that was approved. And therefore, we took this product, known in trials as the Investigational Medicinal Product, or IMP, into the trial so that we could test the product that had a longer shelf life and would at the end of the trial provide a more sustainable product for ongoing use in the NHS. We also had the advantage that we were able to control it and therefore make Dalnido available for the first time in the UK through participating in the trial, and that helped to attract people. If you wanted to use Dalnido in your clinical practice, you could only do it in the context of this trial at that time. So it was a bit of a carrot to try and get people involved. So we took that forward to develop the trial objectives, which were to evaluate whether Dalnido improved myocardial protection compared with St Thomas's in children by reducing myocardial injury as measured by area under the curve for troponin in the first 24 hours, reducing the aortic cross-clamp time, because if it's more efficient and you need to redose less frequently, then presumably you wouldn't spend so much time faffing about giving St Thomas's cardioplegia and the ischemic time would be reduced. And we know that ischemic time is one of the major predictors of myocardial outcome. And we also wanted to see whether it improved clinical outcomes, such as inotropic support or length of stay. Secondary, we wanted to introduce Dalnido cardioplegia for the first time into the NHS, and also to do that as a more sustainable product that could be used more readily going forward. And thirdly, this was the first UK paediatric cardiac surgery to recruit at more than 2 centres. The BRIC trial that was run between 2016 and 2020 was a 2-centre trial, which therefore didn't feature in the systematic review, run between Birmingham and Leeds. I'll come on to tell you a bit more about how many centres we had here. But we wanted to demonstrate that as a community, UK paediatric cardiac surgery could conduct these type of surgical trials. So that became the Destiny trial. So we put it forward as a proposed multi-centre trial, randomizing patients to either Dalnido, the standard in the US, not previously available in the UK, and with potential advantages, or St Thomas's blood cardioplegia, the standard of care in the UK, but with the problem of inefficiency due to frequent redosing. So we applied to the British Heart Foundation, and we got together all 12 centres, as there were then in the UK, to take part in the trial. This was going to be a definitive trial with a clinical endpoint. We were going to recruit 1,000 patients, which in retrospect was madness, and it was going to be expensive. The BHF rightly thought that we were too ambitious, given that we hadn't completed anything that wasn't single centre at that stage. So they invited us for a meeting, which was myself, Massimo Caputo in Bristol, and Peter Brocklehurst, who was previously director of the trials unit in Birmingham. And really, that was a crunch meeting because we had to get across to them the importance of this trial. This was before the priority setting partnership was published, before improving organ protection was the #1 priority. But we sold it to them, and they asked us to resubmit what was effectively a pilot trial with fewer centres. So these things take a long time. In 2019, we resubmitted another application with a 4-centre trial, so Birmingham, Bristol, Great Ormond Street and Leeds, with a surrogate endpoint of area under the curve for troponin, a sample size of 220 and recruiting over 2.5 years. There was a lot of back and forth, mainly cost cutting, and eventually they funded us for 600,000. And as you'll see, that came through in February 2020. And I'm sure I don't need to remind people what happened immediately after that. So our pathway was a bit more challenging, but I'm not going to talk about the results of the trial or the issues that we encountered today. The protocol was published, and the main trial paper is under review at the moment. And really, that work that I've talked about, but also the BRIC trial and some other work looking at myocardial protection came together to, as Natasha mentioned at the beginning, to form my application for a Royal College of Surgeons Huntarian professorship about building an evidence-based strategy for improving myocardial protection, which was awarded in 2023. So moving on to another example. Now this is a work in progress, so I can't share some of the unpublished data, but I can again show you how the framework for developing a trial is being taken forward at the moment. So one of the priorities that was across the board of children and adults was about how we can reduce the frequency or need for reoperations. We know that pulmonary valve replacement is the most common redo operation in older children and young adults with congenital heart disease. But the prostheses that we use are all designed and tested in the aortic position. But we know that the pulmonary circulation has got different hemodynamics. It's got different open and closing pressure to the valve. It's got different ventricular compliance. So why do we think that the outcomes in the aortic position are going to be directly transferable to the pulmonary position? And we know that bioprostheses have one major disadvantage, which is as soon as they're implanted, the clock starts ticking. They undergo progressive structural valve degeneration, eventually leading to valve failure in almost every patient. And that leads to reintervention with a redo PVR or a percutaneous pulmonary valve intervention as a valve-in-valve procedure. And it's quoted at 10 to 15 years, but actually when you look, there's quite a significant proportion of patients who have much earlier reintervention. And we wanted to understand more about that. These patients have a lifetime of repeated reinterventions, and that leads to a physical and psychological burden on them that they've got a valve which is on which the clock is ticking and they will need another intervention, a more difficult intervention because there's potentially a redo procedure and a procedure associated with greater mortality. So what we wanted to do is to identify which valve is best for pulmonary valve replacement. And if we can do that, we can potentially reduce the frequency of reinterventions and improve outcomes. And this is just for context. This is data from Birmingham Children's and the Queen Elizabeth, which looks at patients in whom we've done fallow repair. The dark grey are those who are deceased, but you can see from about 15 years of age, it really takes off in the number of patients having a pulmonary valve replacement. Such by the end of this plot at 30 years, around about 80% of patients have had a reintervention. And we quote people at the time of their initial repair as an infant or sort of early after the age of 1, that they've got about a 90% lifetime risk of having one reintervention. And if you've had one, you're much more likely or very likely to need further interventions. So this graph doesn't flatten off. By the time we get to 80%, it's still going up. But just shows you the burden of disease in these patients. And these are patients really coming out of their teenage years into their early 20s who are needing an intervention. So I'm sure, as you're aware, as mentioned, we use aortic valve bioprosthesis in the pulmonary position. And these fall broadly into two camps. So they're either bovine pericardial valves, and you'll notice that they all look pretty similar, apart from trifecta that's been withdrawn anyway. But there are subtle differences between them, particularly related to how the leaflets of the pericardium constructed into the valve are treated. And then the other main group is porcine xenografts. And again, these look similar shaped frame supporting a porcine aortic valve. And you can see that the leaflets look quite different to the bovine pericardial valves. So using a similar model to what I described before, we undertook a national survey. That was very useful to help us understand what people's current practice is and how they might be willing to be involved in a trial. 70% of surgeons involved in adult congenital or adolescent congenital cardiac surgery routinely use a bovine pericardial valve for pulmonary valve replacement, and only around 7% use a porcine xenograft. The others tend to use homografts when available as their primary choice. However, long-term freedom from reintervention was by far the most important factor for surgeons in understanding what prosthesis they would put in. And we also found that there was a lot of crossover, that people used the same valve in the aortic position as they did in the pulmonary position. And and there was a relative lack of evidence to inform the choice in the pulmonary position. But reassuringly, more than 80% of my colleagues were willing to randomise patients above the age of 16 between these valve types. That dropped off in adolescence because there was a preference for homographs more widely in that group. So it's still a work in progress, but I can just tell you about some of the other work that we're doing to develop this trial. Firstly, as a meta-analysis funded by the BHF CRC as a sort of research development grant, we wanted to better understand the natural history of these valves in the pulmonary position. And we've got a manuscript in preparation at the moment, aiming to submit in the next few weeks. So I can't share the unpublished data with you today, but I can give you the headline, which suggests that the bovine pericardial valves, remember those are the ones that most people use, have a worse outcome than the porcine xenografts that are rarely used. And therefore, this supports our rationale to do a trial to compare what we normally do with what we think might be better. We also went through a very drawn-out process. It took about 2 years to get national data from NICOR, but we now have it on about 3,500 surgical PVRs over 21 years in England and Wales. This work was funded by Birmingham Women's and Children's Hospital charity, and is really providing a wealth of data for us to look at the outcomes of surgical PVR, trends in different types of re-interventions over that time, and the sequencing of different interventions, whether that's surgical or transcatheter. We've also got funding, so I'm currently funded by NHR myself, and as part of that, we're doing an inclusion study. Understanding inclusion and how to maximise inclusion in clinical trials is really one of the core components of applying for NHR funding now. And when we thought about the idea of randomising people between a bovine valve and a porcine valve, we thought that one or both of those valves might be problematic for different groups within society. So we are undertaking a study where we have undertaken a consultation with different religious and cultural bodies to understand their positions. And also we've conducted a series of focus groups with different religious groups, but also with the Vegan Society to understand about people's attitudes towards different types of prosthesis. And the rationale behind this is that we can maximise recruitment to the trial by being explicit about those viewpoints within the patient information leaflet, and also using it to inform site staff so that the research nurses who are approaching the patients are well versed in what the religious bodies think or what information has come out of the focus group. And we've got one more of those to do, and that's been really fascinating. We're also have sort of made the focus group slightly broader. So we're going to use that information to develop a national guideline for all types of bioprosthetic heart valves, whether surgical or transcatheter, to inform discussions and decision-making with patients. PPIE, I mentioned about the focus group next week, about refining the trial design and conduct. And then we've also had an extensive consultation with the major valve manufacturers. The last thing we want to do is to use one or both valves that we start using in the trial, and then they're either withdrawn or they become obsolete, and that would really mess us up. So we wanted to make sure that we understand the position of the different companies moving forward, and they've actually been really helpful and supportive. So that was a whiz through of quite a lot of information, but just to summarise, in the first half, we wanted to answer the most important research questions, and we're looking to understand how to do that through the priority setting partnership to generate national research priorities so that we're conducting the research that matters most. We set up the Congenital Heart Research Network to provide a structure to translate those priorities into funded studies and improve care. And together, these are really a unique opportunity to transform the way that we do research, particularly collaborative research in congenital heart disease in this country. And then the second part was moving from an idea to a trial to understand the types of pathways that you can use, to understand what's known, where the knowledge gaps are, whether such a study is feasible within current practice, and if people are willing to take part, whether that's clinicians or patients, and then any other trial-specific work that you might need to do to better understand the population and to take that forward to develop a trial and apply for funding. So thank you very much, and I'm happy to take any questions.
Thank you very much, Nigel, for a brilliant talk. Before we go on to the questions, I think there's a comment from Adrian Crucian, which I think really summarises and we'll echo our thoughts. So, hi Nigel, I just wanted to say a huge thank you for taking research in congenital heart disease to the most serious level at high standards never seen before. Our community and our patients have benefited a lot. And I think, the projects that you've shown us and the work that you're doing is just amazing and very inspiring. So thank you for that.
Thank you. And thank you to Adrian for such a kind comment.
So we've got a few questions in the chat. So to begin with, how did you build up your research experience to get to the stage of setting up PSP?
Yeah, so I didn't go into my research journey. So I'd always been interested in academia and research, and I'd done a lot of stuff when I was a medical student, projects and house officer and SHO and things. And I was always keen to do significant research. So I took time out of program early on in my training and did a PhD, and that's how I came to Birmingham in the first place. I was at Papworth prior to that, but I came to Birmingham because I wanted to do a trial, and I worked with Domenico Pagano, who was previously professor in Birmingham, and really learnt on the job doing a clinical trial as part of my PhD. And then during my I had a clinical lecturer post, and I continued to develop research during that time, which effectively then turned into the BRIC trial later on. So yes, building up my own research experience. But then from the PSP point of view, really I thought about doing a private partnership for some time, but it was quite daunting because it's quite a full-on thing. And also having the funding is key. And there wasn't really an obvious way of getting the funding. Gavin Murphy had set up and run the adult acquired PSP in cardiac surgery with funding from Heart Research UK. And they were committed to that. I wasn't sure how committed they'd be to doing another one. And also because we wanted to make it broader than just surgery across all of congenital heart disease, I was quite adamant that we wouldn't do it just on surgery. We were fortunate to get funding for that, but it was really having the time and effort to do it and getting the funding that were the biggest hurdles to doing the PSP. And then subsequently, as you might know, there's been a thoracic PSP that they funded through a mix of different sources, and that was the results came out at SCTS in March.
Yeah, no, that's brilliant. And I think you've highlighted, two key areas about funding and the challenges around that with creating these studies and these projects. We've got another question. So as a student, how can we play a role in clinical trials in congenital cardiac surgery?
Okay, so that is challenging for several reasons. First of all, they're still, I've talked about some of the things that we've done, but they're not widely done. So I don't think there is a randomized controlled trial recruiting in cardiac surgery at the moment. The Destiny trial is finished. The PVR trial, the work that I've outlined, has taken 2.5 years to get all of that together, to get the funding to do the work, and we're now at the stage where we're putting in a grant application in 6 weeks to the NIHR for that trial. So I would say it's difficult to get involved in congenital cardiac surgery trials, mainly through lack of volume. Hopefully the PVR trial, we're planning on running it at 9 of the 11 centres. So that would be there, but that's in adult congenital. A better way to get involved in general in clinical trials in cardiac surgery is through the adult setup. So they're much more set up, and there's multiple trials running. So Gavin Murphy, Enoch Okoa are chief investigators of several trials. Those are running across most, if not all, adult cardiac surgery centres. And then the NIHR have an associate PI scheme that people can get involved with locally at their centre to help with the recruitment. So I would say that's a better route at this point in time. Hopefully in 10 years' time, things might be different, but not at this point specific to congenital.
No, that's good advice to get involved in the adult side if they have more provisions at this moment in time. Thank you.
Yeah, and it's learning about clinical trials and how they're run and the things you need to think about. And those sort of generic skills are really useful.
Definitely, yeah. So we have another question. So the concept of a point of no return in repaired TOF is usually discussed in terms of reverse modeling and adverse outcomes after PVR. Do you think such a threshold could also influence the long-term durability of benefit after PVR? For example, by predisposing some patients to earlier deterioration and repeat intervention? Or is it the need for redo PVR largely independent of these factors?
Okay, That's a big question. So I
Yeah.
would say yes. So I mean, the problem in intertrial fallow is that the right ventricle is very good at coping with volume loading over a long period of time, but eventually it reaches a point where it starts to dilate. And over the years, the guidelines for when to intervene have crept downwards, as we recognise that at any given threshold, you may get most patients remodeling, but not all patients remodeling after they've had a PVR. So they're left with a less functional ventricle that if you'd intervened earlier, you could assume, although we don't know, that their ventricular function may have been better preserved. But the problem with intervening earlier is that the earlier you start an intervention, putting in a bioprosthetic valve, you start the clock ticking on the valve, and you may end up need more interventions down the line. And we don't understand about ventricular remodeling and what the differences are biologically in the myocardium between the patients and how they respond to the ongoing stress of volume loading. So there's still a lot of work to do there, and the guidelines are based on generic ventricular volumes. Uh, so for the trial, our best practice is to follow the guidelines. Patients will come through the MDT and get referred and accepted for surgical PVR. We can't change too many things within the trial, so we are going with that approach. Whether it makes a difference, the answer is quite possibly, but we can't really account for that.
No, that's understandable. Yeah, thank you. And then they've also asked another question. What would be the minimum data set or variables you'd want available before attempting a study to investigate whether such a threshold exists and identify predictors of it with reasonable precision? And how would you determine if it is feasible?
Okay, so that's another fairly complicated question. So by the threshold, I'm assuming that you're talking about the point of reintervention of having a pulmonary valve replacement. Yeah, so uh, part of the problem with congenital heart disease, I mentioned about pediatric oncology and things, where the majority of patients are in clinical trials, and because of that, there are much better developed clinical outcome data sets that you can say for all trials. These are the things you should do. We did look at developing that for myocardial protection in children, but there would be a lot of sort of expert opinion rather than data to base it on because there's such a lack of evidence. So in terms of minimum data set, it's tricky. I mean, I think if you were going to do a study looking at pulmonary valve replacement and ventricular volumes and the point of intervention, the reason there haven't been the trials in looking at that in the first place, despite it being a big problem recognized worldwide, is how you do the study. Because what do? Do you randomize someone to early pulmonary valve replacement versus waiting? If you do that, you then have a long follow-up period because you don't know when your patient following guidelines is going to reach those guidelines in order to have a reintervention. So you end up with an intervention arm, which has an early intervention, which could increase their risk of having repeat pulmonary valve interventions, and you haven't really got a good comparator. So there have been people trying to look to do study in this area, but none have been done because of those kind of reasons that it's actually quite difficult to do as a randomized trial. And therefore, the best evidence we have is based on observational data.
I imagine that's a situation with, quite a few ideas that people want to look into is actually the comparative arm and looking at long-term outcomes.
Yeah, and that comes through to understanding where the knowledge gaps are, but then
Mhm.
also with your trial protocol, how do you operationalize that? How do you answer the question? And broadly, if it's not been done, it might be because of a lack of effort, or it might be because it's a bit hard.
Mhm.
We think that doing
Yeah.
a bovine versus porcine trial is low-hanging fruit because you don't change anything apart from what valve you'll get given. It's still going to be the same size, still going to put the same number of
Mhm.
stitches in, but the valve tissue is different, and we've got a protocol for how those patients are followed up.
Mhm. Yeah, no, that makes sense. There's one other question in the chat, and everyone feel free to put your hands up or add further questions in if you have any. So you mentioned earlier on in the talk about upskilling the workforce, and this question's on that. So how can the workforce be upskilled in research, and are there any current initiatives that you're aware of?
Yeah, so really that falls into two things. First of all, there's quite a lot of research training out there already. So congenital heart surgery trial is still at the end of the day a trial. So the NIHR have a portfolio of courses and support for how to run trials and all different aspects of trials, whether that's actually running the trial, whether that's being an associate PI, whether that's looking at things around sort of inclusion and cultural competence, um, and also the Research Development Network, now Research Support Services, run local courses to support different aspects of the sort of design and conduct of trials. So I would primarily point people in the direction of doing those more generic courses. We are looking to set up specific things related to congenital heart disease, whether that's sort of seminars or work packages that people could do. But it is something that we're doing sort of on the side. So we have prioritized more getting things going on the trial side through the Congenital Heart Research Network rather than the training aspect. And that's part of the reason that it was last on the list, because it might be the last thing that we get to.
Mhm. Yeah, that makes sense. There's so many priorities, so you have to focus on the active research. But that's good to know that there are areas that people can look into and courses that they can go on to try and upskill and learn more about research and the different roles in studies and trials.
Yeah, I mean, and also, and if you were thinking about doing a systematic review, Cochrane have an online course about how to do a systematic review, which is really good. So I could definitely recommend that.
Mhm. That's brilliant. Yeah, especially for kind of our medical students who might be interested in research. That's a good starting point. And I think that's all the questions that we have in the chat at the moment. I just wanted to quickly ask, you mentioned that early on in the talk that the majority of studies kind of previously before you set all of this up were like single center studies in the UK. How are you trying to combat that to get more multi-center studies, and what resistance have you found kind of associated with that and overcoming that?
Yeah, I mean, it's a very small community. So I think at last count, there's about 43 congenital cardiac surgeon consultants in the UK. So it's we know each other. I wouldn't say there's been a lot of resistance. There's been not in terms of sort of competition. There's been what we our whole ethos has been about collaboration. And if the BHF had funded us, wild as it now seems, to do a 12 center trial, we would have done it. People had signed up for it.
Yeah.
So, and again, the PVR trial, 9 centers have signed up, and the only ones that haven't are related to using different products. So we hope that that is going to be, if funded, a big collaborative study, and really sort of move us to the next step from a 2 center trial to a 4 center trial to a near national trial. So yeah, there hasn't really been resistance. I mean, people have tried to do their best in the past with those studies. It's just a lack of sort of funding and opportunity, and also historical hangover from really going back all the way to the Bristol Royal Infirmary inquiry and the subsequent stages of safe and sustainable, if you know about that, and all the reconfiguration of services afterwards, has made people or had made people quite inward looking and protective. And so therefore the idea of collaborating was less appealing at that point. From about 2016 onwards, we reached a more of an equilibrium in that centres weren't threatened with closure on a constant basis, and therefore there was more appetite for collaborating. And I didn't mention, but as part of the beginning of this process, I went on a UK and Ireland tour where I visited every centre and talked about how we could move forward with collaboration.
Brilliant. Yeah. No, thank you for clarifying that.
So I've just seen on the
Yeah.
question. So it was Cochrane. So the Cochrane Foundation, if you look on the Cochrane website and look for systematic review course, it's an online course that takes you through how to do it. I think there's maybe 9 or 10 modules, something like that, to do. It used to be free. I don't know 100% if it's still free, but